I'm going to discuss the challenges in the management of urethral stricture disease and go over some challenging scenarios. I'm Shyam Sukumar. I'm a reconstructive urologist at the Baylor College of Medicine. All right, so starting off with nomenclature, urethral strictures are divided between focal and acute types and urethral stricture disease, which is more diffuse. Most of the etiologies, focal and acute strictures, relate to iatrogenic causes versus stricture disease, which is usually inflammatory or infection related. The etiology of strictures is roughly a third are iatrogenic, a third are idiopathic, and a third are either inflammatory or traumatic. The workup is pretty standard with office-based studies, including cystoscopy, RUG, and Bougier-Bull. All right. In randomized trials, it's been identified that symptoms usually manifest when the lumen of the male urethra is less than 16 French. It's pretty convenient, given our scopes are about the same size in the clinic, and this alone is about 90% sensitive and approximately 70% specific. In terms of management and outcomes, we have endoscopic and reconstructive options. In terms of minimally invasive methods, DVIU, balloon dilation, including Optilume, are options. The urethrotomy, especially the older series, did have some pretty significant complication rates, specifically having to do with bleeding, as you can see in the various studies here. Success rate is not that high for DVIU, especially after repeat DVIUs, and this has been pretty well established. These are Kaplan-Meier curves from the South African study. The success rates after the first DVIU were actually around 8 to 10%, even though it's coded to be higher in the older studies. So it's lower than what most people would think or most patients are being counseled about. In terms of DVIU success and location, choosing the right patient is paramount. Picking patients that have strictures in the bulbar urethra and that are short is important. And patients that have not had repeat DVIUs. All right, so the most cost-effective way to look at this would be if it's a patient who has a short stricture in the bulbar urethra first time, then one DVIU prior to reconstruction is reasonable. If it's over 2 centimeters, then talking to them about reconstructive options, I think, is the way we approach it in clinic. In summary, endoscopic options don't have high success rates. They are okay for select patients, but further attempts should be avoided. All right. Moving on to reconstruction, urethroplasty is basically just a urethral flap surgery in most instances, and it relies on the bipedal corpus spongiosal circulation. The blood supply of the urethra is shown here. And the bipedal blood supply is pretty important. So even when you detach the distal urethra from its proximal blood supply, you have the circumflex circulation and you have the dorsal arteries that then decussate in the glands and provide a retrograde circulation. So that's why the distal part of the urethra is able to survive despite transection. Some of this is affected in patients with hypospadias, where there's spongiosal atrophy, and so that retrograde circulation is affected, so you should be very careful in transecting anyone with hypospadias. In terms of different ways to bridge the gap, there are different maneuvers. The first one being you mobilize the urethra all the way to the penoscrotal junction. You take down the tendon so that you can rock the bulb forward, and that is usually enough in about 80 to 90% of cases to get the two ends to reach. You can either do a parachute anastomosis as shown here. Different experts, use different numbers of sutures. I've moved from using 12 sutures to 8 sutures, and I'd be curious to see what Dr. Coburn thinks when we discuss this later on in the panel. But I think having 8 sutures properly placed with mucosa to mucosa approximation is probably enough for good outcomes. Pelvic fracture, urethral injuries are more challenging cases where, the proximal end has to be fished out and oftentimes involves a pubectomy to get access to allow for tension-free anastomosis. You can also use ski needles, as shown there, and the back of your DeBakey to be able to get a good bite of the mucosa. So these are the ski needles that we sort of fashioned for the deep bulboprostatic anastomoses. It allows for easier rotation of the sutures deep in a hole. For cases where we think we're going to do an anastomotic urethroplasty going in, but then it turns out that the stricture is longer than expected, you can usually get one end of the urethra to reach, and the other end can be augmented using a buccal graft. This is a similar situation to what we do with the ureter. In the proximal ureter, if you can do a direct pyeloplasty, you can do an augmented anastomotic and put the buccal graft posteriorly on the psoas or anteriorly and then wrap some momentum around. It's a similar concept. If just mobilization doesn't get you to get the ends together in a tension-free manner in more challenging cases, especially for pelvic fracture, urethral injury patients, you can split the corpora, spare the dorsal vein, and oftentimes tie it off if you're not able to mobilize it to the side. And this allows for a tension-free closure, as you can see here. So the curve of the urethra is just more attenuated and earlier, and that allows for the two ends to come together easily. And then in more challenging cases, after you tie up the dorsal vein, oftentimes you have to get a rongeur and a mallet and go to work on the inferior part of the pubic bone. You don't have to do a total pubectomy. I think the inferior wedge, an omega-shaped wedge, is usually enough to get the ends to reach. And that is why this works. Again, the curve is earlier, and so the urethra is able to curve under the pubic bone there and reach the proximal end sooner. In extremely challenging cases, rerouting has been discussed, but this is usually necessary extraordinarily rarely, and it's not usually necessary to get the ends to reach.